Hello, everyone. Welcome to Nursing 204, yet another skills lab video for us. Today we're going to talk about NGs and NG insertion, and then we're also going to talk about PEG tubes. We're also going to discuss administering crush meds through these tubes and how to do it, what to watch for, all that good stuff. You know, we'll cover the bases as best we can, that's for sure. So, insertion of a nasogastric tube. So that is a tube that goes down into the stomach. Usually the tube is used for decompressing the belly. Maybe there's a lot of air in there, or getting rid of nasogastric drainage. Sometimes patients have bowel obstructions, or sometimes they're throwing up a lot, and so sometimes the doctor just wants to give the patient's stomach a rest for a little bit. So those are oftentimes reasons. Also too, if the patient is intubated, if they have a tube that's going into their lungs and they might be on a ventilator, then to protect their lungs and avoid any sort of aspiration pneumonia, then an NG tube will be inserted. So that's kind of an overview of reasons for why you might have an NG tube. So initially, you want to introduce yourself to your patient and you want to tell them what you are going to do. So I'm a firm believer, no surprises. Nobody likes surprises, and patients don't like that either, especially when they aren't feeling very well. So try and just give kind of a simple little explanation that the doctor is wanting you to put a tube into their stomach to just help relieve the nausea or help to empty out their stomach. So you can keep it very simple. So initially, you want to set the patient up in the high semi-Fowler's position, which means the head of the bed is elevated as high as you can get it. And then you also might want to gatch the knees a little bit, elevate the knees a little bit so they aren't scooting down in the bed. But go ahead and sit the patient up high in the bed. Then I'm going to start preparing, and we'll talk about all the equipment. So I like to just get a regular bath towel and put this across the patient. Then if there's anything that happens, you have coverage of the bedding and the front of the patient. You can put a chucks underneath there as well if you want something that is coated so that if they do happen to throw up or anything, this won't seep down through your towel. So get a towel. You're going to want to give the patient an emesis basin. You also are going to want to give the patient a glass of water with a straw so that they can take sips of water. And you might need, depending on your patient, you might need a buddy to help you with giving the patient a glass of water. So just bear that in mind. Then you're going to want to get a Salem sump NG tube. Salem sump tube is what is called stomach tube. And you want to make certain that it has this blue vent on it. Also too, you want to make certain that you have the plug, the valve that goes at the end of the vent. And we'll talk about that when we start inserting it, but you really want to make certain you have this. This is your friend. Trust me, we'll talk about that more. Then you're going to want to get some KY jelly for lubricant. You're going to want to get some tape and a safety pin because you're going to want to secure the tube to the patient's gown once you get things inserted. You also want to tape the tube to the nose. So you have your tape for that. I also recommend, I'm not certain why I had that Sharpie pin.
To mark the tube instead of tape.
Oh, yes, excuse me, that's right. I forgot for one moment. You can mark the tube either with a marking pin or tape for knowing how far in you should insert the tube. You want a flashlight because you want to look up the nostrils, look down the throat. So make certain you have a flashlight. You're going to want a small strip of pH paper That we will use after we have inserted the tube to just check and make certain that you have GI drainage, and it'll tell you kind of how acidic it is. Then I got an irrigation container with a syringe. You definitely want a syringe so that you have that for checking tube placement and also for flushing the tube. So, okay. I'm going to go ahead and get things set up a little more before I start instructing my patients what all I'm going to do. So, yes, I did. I'm going to put on my gloves first. And these can be clean gloves. You don't need to have sterile gloves. So, I'm going to talk about the tube for a minute. So this little piece right here, this is your connector from your NG tube to your suction. So you definitely don't want to lose that. Then this is the valve that I was talking about. And I don't know if you can see it, but there is a hole right there. And the purpose of the valve is, it used to be that there weren't valves, and what was happening was with suction, this tube was sucking up against the stomach lining and it was creating ulcers in the stomach. So they came up with the new idea, and this works really well, to create the vent. Yes, exactly. So you want to have this because when you insert this NG, what can happen is you have now put a channel for gastric juices to come out. So what you want to do is make certain that you close off your vent so that the gastric juices don't start pouring out of this vent. So the way this little plug is, you can see, maybe, there's a hole in the bottom of the blue there, and then you can see at the base right here of the white, there are a lot of little holes. So those are little air vent holes. You'll attach this by placing blue to blue. So go ahead and get that in place. You'll want to do that right off the bat so you don't forget. Trust me, it's not fun. Notoriously, this will go in your shoe if you don't do it. So trust me, it's best to get yourself protected there. So initially, what you want to do is you want to measure the tube for how deep you should go. And if you look on the tube here, you'll see that there are little slash marks and there are numbers on there. So what you want to do is go from the tip of the nose to, let's see if I can do it on this side so you can see better. Tip of the nose to the top of the ear and down to the bottom of the sternum. So as I measure, this looks like I'm probably wanting to go, according to the measurements, it looks like I want to go to 55. So I can either use a marking pen and mark it, or I can just take a little piece of tape and mark it as well. So hold your finger on there, because notoriously if you move it, you'll forget what your number is and you remeasure again, which is a-okay too. So there, now I have marked that so I know where my stopping point is. Okay, so you have your tube ready to go. You have your water ready to go. You have your lubricant. Now, with lubricant, you want to make certain that you have enough to lubricate the tube, but don't goop it on because that will gag your patient, trust me. So I usually just find a little spot on the towel, thank you, and just put a little dollop on the towel. And then what you want to do is you want to coat the tube a little bit. So you want to look at it and make certain that there's lubricant on there, but you don't want to gob it on. So I'm going to let that sit there for just a moment. So I've got everything primed and ready to go. The other thing that I may do, I'm going to remove my little connector and pay close attention to where I put it, but I'm going to go ahead and put the syringe on the end here, because this too is another opening where the gastric drainage could come out, and I don't want it in my shoe. So the next thing you want to do is assess the patient's nose and their nares. Now then, interestingly enough, our noses are constructed in a very unique way. Depending on kind of what your ethnicity is and where you are from, oftentimes has to do with the structure of your nose. So in warmer climates, they have much shorter noses, and they're usually upward a little bit more, and when you look into their nostril, you'll immediately see that there is, they don't have a long nasal cavity here. It basically goes into the back part of the nasal area into your throat. So it's very, very close to the end of your nose right here. I'm not explaining this well, I'm sorry.
Nasal pharynx.
Your nasal pharynx, yes.
Pharynx.
So it's very short. If you were to assess people's noses in Minnesota or colder climate areas, Alaska, you would find that their noses are bigger and they have a larger nasal cavity area. And that's because in warmer climates, they don't need as much nasal space to warm the air that they breathe, but in colder climates you do. So that does make the difference. Also too, you want to ask the patient if they've ever had a deviated septum, if they've ever broken their nose or anything like that. That's something you want to take into consideration for as far as which nostril you want to put the tube in. And then you can also look in the patient's nasal area and just see if you're seeing any sort of deviations or any sort of obstructions that are going to interfere with your inserting the tube. So everything looks good to go. So make certain that your patient has the water in their hand, or make certain that your buddy is by your side helping you. So, thank you. So Annie, I'm going to insert a tube down into your stomach now. It's going to go into your nose. And initially, it's going to feel kind of funny and kind of tickle. And then there will come a time where it will be important for you to take sips of water and swallow them. And we'll go ahead and just get the tube inserted, okay? So I'm going to talk you through the process, and no surprises, okay? So the patient will, as a reflex, reach up and grab your hand and try and not allow you to insert the tube when you start. Just know that. So make certain that your buddy is with you and helping with hands for protecting the tube, most definitely. So, okay, Annie. So go in initially. You want to head for the ear. So don't go straight up. You want to go in and head for the ear. And right up at the top where it goes into the back of your throat, in the nasal cavity there, you're going to kind of hit an obstruction. And at that point, that's when you need to lift up the tube, and the tube will slide over that and start going down. So you insert the tube.
And talk about the earlobe versus the ear. Yeah, they want to head to the earlobe.
Oh, excuse me. Yes, Karen brought up a really good point. So you want to head the tube towards the earlobe, not the top of the ear, because that's kind of like up, straight up. So head more towards the earlobe. So it's kind of at an angle that way. So then you're going to hit a spot where it's going to start making them cough and gag. This is when you want to have the patient start taking a sip of water. So when they take a sip of water, and you really want ice water, that helps to numb the throat, so it makes it a little bit easier with insertion. So when they take a sip of water and they swallow, that is your go time, okay? So she's taken, Annie took a sip of water, she's now swallowed, and I go. Just, you know, a few inches, 3 inches or so. You don't want to just keep ramming it in. So give her a breath for a moment, let her catch her breath.
Don't let go of the tube.
Don't let go of the tube, exactly. As I let go of the tube. Then have her take another sip of water. And she's taking a sip of water and she's swallowing it, and you go. So the reason for why you want to go after she swallowed the water is because the epiglottis has gone over the trachea to protect the airway. So you want to make certain that, did I say that right?
Mm-hmm.
Okay. You want to make certain that she has swallowed so that you are getting the tube in the right place. If you are not getting the tube in the right place, the patient will cough and gag and choke, and you will know that you are probably going down into the lungs. So you need to be very, very careful about that. So Annie will continue to take sips and swallow. Take sips and swallow. Take sips and swallow. I got too far back on the tube. Take sips and swallow. So that gets you into the place. Perfect. So hang on to the tube there. You don't want to let go of it, like Karen said. So initially what you want to do is draw back with your syringe, and you should start seeing some tannish green drainage. You might see clear because you just gave them a fair amount of water, but you'll want to draw back and get some drainage. You want to verify that you are in the proper place. Now then, could you possibly go ahead and put some drainage in on your pH paper? And what is that telling us? It is telling us that there is gastric acid. So you know that you're in the right place. So, lost my train of thought. Okay, so the other check that you can do, well, let's go ahead and tape it since we're pretty certain with that check that we are where we need to be. You want to tear a piece of tape that looks like a pair of pants. Can you see that? You tear it right in half. So make your pants, place it on the patient's nose, and then one leg goes this way and you wrap it around the tube, and the other leg goes the other way. And you might want to take your marking tape off just so you get a better security on your tube. But go ahead and get it secured like that. Good. So the other check that is good to do is do an air bolus check. And it might be the ATI has a conflicting explanation for this, but when you do an air bolus check like this, you're going to hear a glub sound, and that does help to identify it as well. That means you've done 2 identifiers to make certain that you're in the proper place. So you only need 30 mils, 40 mils. You don't need a whole lot. But what you want to do is attach this to the end of the syringe. Then you listen right here at the bottom of the sternum. And then you go ahead and just give it the air bolus, just give it a little sharp push of the air. And you'll hear a glop sound in the abdomen. That helps to confirm it. Also too, there is a radioactive white strip on the tube. So radiopaque, thank you. Radioactive. Oh, that'd be great. Radio peg tube or strip, excuse me, on the tube. I don't know if you can see that there. It's a little bit kind of vague. It's right here. So what that means is if they do a chest x-ray on the patient, this strip will show up on the x-ray, and that's another way of verifying for sure that your NG is where it needs to be. So once you have that in place, you can put your little connector tube to the suction, put that in, and you can go ahead and attach it to your wall suction. Now then, should I turn that on?
Yeah.
It's kind of noisy, but usually the doctor will say, put the NG tube up to low continuous suction. What that means is usually you want the suction to be about 150 to 200. You don't want it up very high. This tube, because you have the vent, it should not suck up against the lining of the stomach. However, sometimes you'll notice that there doesn't seem to be drainage moving through the tube. So
Pain.
and they're having increased pain. Hopefully they aren't getting increased bloating to show you that, you know, they're increasing the amount of fluid in their stomach. Hopefully we won't be experiencing these sorts of things, but those would be the sorts of things you'd want to watch for in case there were troubles at all. But sometimes there can get to be a little airlock in the tube, or sometimes the tube can kind of suck up against the wall. So you want to do an air bolus into the tube or a little bit of irrigant sterile water and just flush the tube just to make certain that it's patent. If there is bleeding, there can be blood clots, and that can occlude the tube, so you want to pay attention to that, most definitely. But when this is on, you should hear a little whistling sound, and you want to make certain that there's no drainage in your vent tube. If there is drainage in your vent tube, it will create a vacuum so that the tube is not suctioning. And so that is then when the tube will suck up against the stomach lining and create problems. So if you notice that there's some gastric juices in the vent tube, then you want to air bolus this vent and try and push it through so you clear that out so that the vent is then open and will continue to create that vent purpose that it's intended for. And yes, Karen brought up a good point. You can also turn the patient. That helps as well. So, okay. Now then, another check that you can do, you can have a tongue depressor and your flashlight, and you can look and make certain that the tube, you can see the plastic tube running down the back of the patient's throat. So that is another check that you can do as well. To secure the tube, you want to make certain that you have given the patient, given the patient enough leeway that they can turn their head side to side and move their head around without the tube getting pulled on. So make certain, I think because of my suction, I don't have a lot of leeway, but make certain that you're giving the patient enough room to move. Then I just wrap the tape around and double it back over on itself and kind of create a little tab here, a tab of tape. And then you pin it to the patient's gown. Okay. Like that. Okay. Now then, crushed meds. We'll talk about that a little bit. So crushed meds. When you are giving the patient their medications, usually you clamp their tube. You'll be clamping their tube for probably a half an hour or so because you want the patient to absorb their medications. So what you do is, if it's in tablet form, you crush the meds very fine. This is a powder. Karen, mix this up. Thank you. So it's down to a powder. And what you do is you put in water. You don't want a ton of water, but you want some water. Thank you. I'll put some in my little container here. So you want some water. You want it more thin than a paste. I think I'm going to switch to the plastic cup. Maybe. Switch to a plastic cup. So put the water in there. Then you can use your syringe to mix it up. Sometimes it takes a little bit. That powder just doesn't want to incorporate in with the water sometimes. So it's kind of about the consistency of Ensure. And so that would probably be about the right consistency. You want it, you don't want it thick like applesauce, because that is just going to plug up your tube, and trust me, it's no fun to have to do this all over again. So
Or to put a new tube in.
put in a new tube, exactly, exactly. So suction it all out. You may need to do it twice just to get at all the meds that are in your med cup. Swirl that up to kind of loosen it. Then I'm not going to do it because Annie doesn't have a real stomach. But anyhow, you would separate this and you would go ahead and you would inject the meds that are in a liquid form in, and make certain that you get it all. Flush with about 5 cc's of sterile water to make sure all the med is down the tube and into her stomach. Then what you can do is, I'm going to empty that out as if I've given it. Making a mess. So then what you can do is just clamp this off with the syringe.
You can use the wide end.
Yes, you can use the white end too. Thank you. Absolutely. Do something to clamp this off so that it is not coming out of the tube. Because once again, when there is a channel for liquid to move, it will come out this tube. It will just automatically, gravity and all those good science laws, guaranteed it's going to come out that tube. So to make certain that the patient is getting their meds, most definitely make certain that you're clamping things. Then you want to keep track of 30 minutes, most definitely, because if they have an NG in, there's a reason for it. So you really don't want to have it clamped for long periods of time. So once you come back and you're connecting them, you'll want to flush with a little water, or you can also do just a little bit of an air bolus and go ahead and hook Annie back up and go ahead and turn on the suction. You may see some pill fragments, but it should be mostly absorbed. And so pay attention, make certain that your tube is working, functioning. So I have a little coil right there. You'd want to make certain that that does not get kinked in any way, but make certain that everything is flowing and that you're getting the removal of drainage again. So with an NG insertion, you would want to document date, time, which nair you place the tube, what centimeter level did you insert the tube to, and that's important because in case the tube gets dislodged, they need to know how far in you had inserted the tube. You want to talk about color, odor, drainage, amount out of the NG tube, how the patient tolerated it. And I think that's it.
Yeah.
That's all I can think of. So
What you said measurement, right?
the measurement,
Oh, yeah,
yes.
yeah.
How far in it was
Yeah.
inserted, yes. Absolutely.
So you can find out if they pulled it out.
Yes, yeah, because they will, especially if they're kind of out of it and not really aware of things, they will pull the tube out, guaranteed. So, thank you very much. If you have any questions, feel free to direct them to us. Absolutely. Take care. Bye for now. You go. So, I just received an order from the doctor that we could discontinue the NG. So what you'll want to do is you'll want to gather your equipment and supplies. So don gloves. He must. Then you're going to want a towel. I'd get an emesis basin just in case, because the patient may kind of gag a little bit with pulling the tube out. You'll want a box of Kleenex, most definitely. So initially, you're going to tell your patient, the doctor just told us that we can take the NG tube out. Yay! So just coach them through it. So what I'm going to have you do is just take some slow, easy breaths, and we will remove the tube gently and hopefully without creating any sort of discomfort to you. Usually people have a sore throat with an NG tube, so removing that tube there's a bit of relief from that. So initially what you're going to want to do is make certain that you disengage the NG tube from the patient's gown. That's a real good must. So then what you'll want to do is you'll want to carefully remove the tape off the bridge of the patient's nose. Hang on to the tube. Then you want to get a tissue. This is where your tissue comes in hand. Put it up. Up here on the bridge of the nose, and then have it clamped around the tube gently. Don't grip it, just gently. And then tell your patient to take some slow, easy breaths. And as they're doing that, it's one swift, gentle pull, and out it comes. The patient may want to blow their nose. You may need to wipe their nose. You don't want to whip the tube out. You want to just do a strong pull and get it pulled out. The patient may cough and sputter a little bit, but usually they're so relieved to have that tube out that they're thanking you.
You're their new best friend.
They're your new best friend, exactly, like Karen said. So that is how to remove an NG tube. And then, of course, you would want to document what date and time for when you removed it, how the patient tolerated it, and I don't think that it's necessarily recommended that you're doing color, odor, consistency discharge, unless you are seeing some blood clots or something. That might be noteworthy. But you're also then, after getting the tube removed, you want to assess bowel tones. You want to make certain that you've got active bowel tones. You're checking in all 4 quadrants. And the way you do that, you divide the abdomen in half and use your umbilicus as one of your landmarks, and then divide it vertically. You want to use your umbilicus going up and down. Horizontally, you want to do it straight across the abdomen with, again, your umbilicus kind of being the center point. And then you'll want to listen in all 4 of the quadrants. You want to hear bowel tones. You want to hear some gurgling in all 4 of the abdominal quadrants. So it may not be real brisk at first. Might just kind of, sometimes the sounds are like static, like you're moving the stethoscope over fabric. They could be real faint. So sometimes you really have to listen for it, but that is definitely something you'd want to assess for. And then is our abdomen soft, flat, non-tender? Those sorts of things would be wise to address as well. So I think that's the end of taking out an NG tube. Thank you very much. Bye-bye.